We live?
Yeah.
All right.
Sorry, some technical glitches. We're up and running.
So Dr. Joe Kent, Dr. Dan Blizzard back with you. Last time we talked about some bulging discs. This time we're going to discuss a little bit about lumbar spinal stenosis. So to get things going here, what is stenosis? And so stenosis basically just means narrowing. And that narrowing can come from a number of different places in your spine. The areas that we think about the most when we're doing an evaluation is it central? So central canal stenosis? Is it in the lateral recess, which is lateral recess stenosis, or in the foramen? And where those are going to be here. So in the central stenosis, I want you to start looking at the screen on the left, and you'll notice that across approximately where that red line is the spinal cord coming down here, and you can see that it kind of bunches up right in the middle there. And so when we see that, we look to the screen on the right, which is a different slice, to see how bad that narrowing is. And what we see there is you can see that the white, there's only a few specks of white, and so that can represent some fat, or that could represent some spinal fluid. Regardless, there's not a whole lot of space around those spinal nerves in the middle right there. So that would be what we call central stenosis. The next area that you can have stenosis is in the lateral recess. And so if you compare the last image to what we see in this image, you'll see that you can see those individual, nerve roots, those little dots in the middle of your screen. But there's a little bit of narrowing kind of in the corners, and that can be what's called lateral recess between that disc, which is just at the top of the screen, and the facet joints, which are on the bottom of the screen below that area. The next area that we commonly look at is what's called foraminal stenosis. And so this is a little bit farther outside your spine. And this can, if you look at the bottom of your screen, you can see that the first arrow up on top, you can see that there's that circular structure, and that's the nerve. And then the white around that is fat. And so in that case, that nerve, seems to have some space around it. It may be kind of coming up close to the disc at that location. But if you compare that level to the area in the arrow right below, you can see that same nerve, there really isn't a whole lot of space around it. And so that would be what we would call foraminal stenosis.
You want that to look like an egg yolk. When you look at that picture on the top picture with the arrow, you see the egg yolk in the middle, which is dark, and the white around it, like a fried egg. If you go down a level, you don't see the white around it. The white is fat and is cushioning around the nerve. So if I can see white circumferentially around a nerve, I know there's enough space around it where it's not getting compressed. And the arrow down below, you can see there's not egg white all the way around it. That nerve is getting compressed by the bone from above and the disc from below.
So what causes the narrowing? We briefly touched on it a little bit earlier, but these narrowing can be from bones, or what are called osteophytes. If you read your MRI reports, they can come from, and the osteophytes, if you look up at the bottom right screen, you'll see some osteophytes. The easiest way is you can see them at the front of the spine there. Those aren't near the spinal cord, but those are kind of what they look like on an x-ray.
And osteophytes are bone spurs. That's when your body has any arthritis, it makes bone spurs. Anywhere in your body, your knees, your elbows, your fingers, your spine, arthritis, your body reacts by making bone spurs.
And another thing that can cause narrowing is what's called spondylolisthesis, which is just a fancy word for a slip disc. And that's represented in the upper right-hand corner, where you have that bone's just shifted forward. Other things that can cause it, the herniated disc, that's kind of what that's what we covered the last time we had our talk. But that can be just from a disc bulge or disc protrusion, extrusion, just different flavors of that disc pushing on the nerve structures. Another thing that can, one of the others is called ligamentum flavum hypertrophy or buckling. So this is the bottom left-hand screen. You can see that there's quite a bit of narrowing at that level. And part of it, the reason is because the ligaments, some of these ligaments that you have running along your spine just become enlarged. And that buckling can come as a result of some structural issues. And that can contribute to narrowing of the spinal canal at that level.
So in the upper left picture, that triangle of white that you see in the middle is where all your nerves live. Even in this case, there's a cyst on this joint that's protruding into this triangle. But in general, you can still see a white triangle. So this is not terrible stenosis. This is not severe. Down below, that triangle is completely gone on this person because all that ligament Dr. Kent was talking about is now filling in the space of that triangle. That triangle is reserved special territory for nerves only, and nerves need that entire space to exist and be happy. And the minute things start filling that space and taking up space the nerves could otherwise have, things like disc herniations, too much ligament building up in there, the nerves start getting starved for space and they become unhappy.
Okay. So who gets spinal stenosis? And so it's one of the most common causes for lumbar spine surgery. And this is going to be in patients over 65 years old. That's also about the average age of presentation. So when patients start showing up with low back pain, and we'll talk about specifically about the symptoms that we look for, but that often happens around that 65 years old, start of the golden years. The next most common location is going to be the L4-5 level. And do you have any reason why that L4-5 level seems to be?
It has to do with mechanically, the lower down your spine you're talking about, the more load it bears. The very bottom level of your spine bears all the weight of all the levels above it. So if you can imagine, if you're measuring how much force each disc in your body has to absorb on a daily basis, the one at the very bottom is bearing the most amount of weight because you have the most mass above it. The second reason is the way these levels mechanically line up. I think if anyone who's seen their MRI or an X-ray before knows that you have natural curvature to your spine, and you need that curvature to give you balance, to give you mobility, and to make your body not have to fight to keep you standing upright. But because of that, the very bottom, there's certain slope that these levels have, and the L4-5 level, in addition to bearing, is more weight than any other level except for the very bottom one of L5-1. It's bearing all the weight, and it's mechanically in a position where the disc wants to slip because it's getting a shear force as your body pushes down with weight and pushes forward.
Okay. And so risk factors along with that, obesity, that the more weight you have going, have that downward pressure causing those shear forces on the lower part of your spine, the more likely you're going to have degeneration and issues at that level. Some other things, Caucasians tend to have it more commonly. Congenital anomalies can contribute to this, likely related to different architectural changes to your spine. All right, and so symptoms. So when these are the symptoms that when you come in for an evaluation, these are going to be the things that we're looking for. We see a lot of patients with back pain, and this is one flavor of back pain, but it's also commonly associated with buttock pain. You can have pain down the legs. It's typically worse with extension, so standing, walking, and gets better when you sit down or flex forward. That's why we may hear us ask you if it gets better if you need a shopping cart to walk around the store. And that can be signs that architecture of your spine, that normal kind of extension, puts more pressure on those nervous structures, and flexing forward takes out a little bit of that curvature and can take some pressure off those nerves, which is why people tend to walk around leaned over, because it makes them feel better. Other symptoms that may or may not be there: weakness, especially weakness when you're standing and walking. That gets better when you sit down. There can be some bladder disturbances. And then kind of a end stage rare thing would be this Cauda-Equina syndrome. You want to talk a little bit more about that?
So the very bottom of your spinal cord is a actual cord, like a rope, all the way throughout your neck and your thoracic spine. But coming down between your thoracic and your lumbar spine, that rope turns into individual nerve roots. And Cauda-Equina is Latin for horse's tail. So it literally looks like a horse's tail with hairs. So at the very bottom, when it's just nerves down there, these nerves can get pinched in such a severe way that they can pinch off any transmission of input from that point further. So when this happens in the very bottom of the lumbar spine, this is something that can only happen in the lumbar spine. The nerves will get pinched so much that you lose control of your bowel and bladder function. You can get very severe numbness in your groin and around your butt. And when this happens, it becomes an operative emergency. In all the spine surgery, there's very few things that we consider to be emergency, but this is one of them. And when this rarely happens, and again, it's hard for this to happen without a real trauma or some traumatic type event. But when this happens, we have 24 hours to get to it. If we can't get to it within 24 hours, the outcomes afterwards drastically go down.
So Moving on, so what do we have for treatment options? And this will be kind of the remainder of the talk is what do we do about these things? We're going to talk about some pain medications, neuropathic pain medications, physical therapy, some various injections, and then various ways to relieve pressure on those nervous structures. So neuropathic pain medications, these are going to be things like gabapentin, pregabalin, duloxetine. You can see the trade names off to the right there. These medicines, how they work is, when nerves get irritated, they send signals very quickly. And so these medicines, primarily the gabapentin, pregabalin, kind of reduce the quickness of that nerve fibering to help relieve the symptoms. Are they going to change? Are they going to, treat any of the root cause of the issue? No, but they will treat the symptoms of the issue, meaning pain. And pain is, that the symptom that people feel that typically drives them to want to see a doctor and have things done to their, have treatments done. These medicines are not without side effects. Typical side effects from them are going to be things like dizziness. They can make you a little forgetful, fatigue, feel like you're thinking straight. And so, while these medicines can be very helpful, you have to always, balance risks and benefits. And these will be things that we'll sometimes try. Again, we try them and see how they work, and hopefully, limited side effects. But these are, some options that we have. The next thing that we typically get patients in to do is physical therapy, and this will be probably the first thing your primary care doctor will send to you to start working on if you have back pain or weakness. And what they can do is make sure that you're as strong as possible. Is physical therapy going to change any structural problems with your spine? No. But what they can do is they can have you get in a proper, gait, engage certain muscles, and so you're optimizing the body mechanics to limit the type of pain, limit the amount of symptoms that you have. And physical therapy will often bring people to a plateau. Sometimes that plateau is good enough and you don't need anything else. Sometimes the plateau is not good enough, and that's why we have some of these other treatments that we're going to talk about.
So I explain this to people, if you don't have any core musculature, no core in your front or your back, in order to stand upright, you're 100% dependent upon your bones and ligaments to hold you there. If you have stenosis, you have discs that are degenerating, they're bearing the load. And if you don't support it with muscles around it, you're going to keep on depending completely upon your disc and your bones to hold you upright. So what does physical therapy do? If you strengthen the muscles around your spine, they can offload some of the demands you're putting on your disc and your ligaments to keep you standing upright. I'm sure everyone's seen someone who's, it's almost always an elderly person, who's walking forward, bent entirely leaning forward like they're stooped over. That person, the reason why you degenerate to that level is, one, the more the discs wear out, the more you pitch forward, but two, they don't have the strength of the muscles in their body to keep them holding upright. So as that person bends forward, it's a circle of making you more and more degenerative. The more you bend forward, the more fatiguing that is, because it's very hard to sit bent forward the entire day and survive a day like that. But also, the longer you pitch forward like that, the more it keeps on degenerating you. So physical therapy can put you back in a position where you're taking the least amount of energy and straining your body to stand upright and go through the day.
All right, now we're going to talk a little bit more about, what are some interventions, some procedures we can do to help with pain from spinal stenosis. Epidural steroid injections are a type of injection where a needle is placed in this epidural space, which is a kind of a potential space that sits behind the nerves, but in front of some of the ligaments. It's not right along the nerves where the goal is not to get along the nerves and around that spinal fluid. It's supposed to sit kind of behind that area. But we use various imaging and different techniques to basically access that space. And once we're there, we can inject steroids. Steroids, and people commonly ask, how is it going to work? How long is it going to work? And those are difficult questions to answer. Our research tells us that they do help with pain, but how long they last for and what kind of relief, it commonly comes down to what's causing the pain. If patients have a new onset, symptoms going down their legs from some of the stenosis, oftentimes those are the people that respond very well to these epidural steroid injections. Part of the reason with that is typically when you have these, especially from a bulging disc, that type of thing, they do get better with time. And so these steroid injections can buy time, get you more comfortable, allow you to engage in physical therapy, to work on core muscle strengthening. And so it gives your body the ability and time to heal and participate in physical therapy. Are these going to help for everyone? No. And sometimes, when you get to a level or a degree of narrowing or stenosis in your spine, these stop becoming effective, or the amount of time they're effective becomes shorter and shorter. And so these are typically something that can be tried early on to help with pain. If you get prolonged relief from it, then that's something we'll do periodically, because the goal is to keep people functioning, people out of pain. And if we're able to do these in at least invasive as possible, such as doing these epidural steroid injections, then that's usually the first thing we'll go with.
From a 30,000-foot view, what a steroid injection does is take inflammation locally out of an area. If a nerve is pinched for any reason, when it gets pinched, it wants to react by swelling. If something's in a tight area, it gets pinched, it's going to want to swell, which makes the tight area that it's in seem even tighter. So a steroid injection can calm down inflammation a nerve has from it being pinched. When you look at someone's MRI and you see nerves that are in a tight place, we're getting a snapshot of what it looks like with an MRI. When that person gets up through the day, bends forward, bends backwards, trips and falls, the space in their canal changes dynamically or throughout the day when that stuff happens. So it may look like a nerve is kind of getting pinched in an MRI, but it may have been that 2 weeks ago when that person fell, it temporarily got very, very pinched and then relaxed back to normal. So the nerve afterwards swelled up, and now it's very, very painful. So an epidural steroid injection can calm that particular nerve back down. And maybe that when we shrink it back down to its normal size, even though it's still a little bit pinched, it's not pinched enough to cause a symptom. So does it change the structures that are pinching nerves? No, but it can change how unhappy a nerve is about being pinched.
The next thing we're going to talk about is a newer procedure. It's called, the company's name is Vertiflex, and it's technically called an indirect lumbar decompression. And Dr. Blizzard is going to talk with you about what a direct decompression is all about. This is kind of a halfway point. This is kind of not quite a full-blown, big surgery, but this can often provide significant relief, or maybe you don't need a surgery, or maybe it kicks that time until you need a surgery down the road a few years. So what this entails is basically putting the small spacer, you can see it's on the left side of your screen there. Now this is a 12mm size, in between the spinous processes, or the little bones that stick out of the middle of your spine. How it works is, when we talked a little bit earlier about body mechanics, and when you stand up, it tends to collapse the area around the nerves and cause symptoms. And that's why patients tend to have worsening pain, worsening weakness when they're standing and walking, and when they flex forward, that pain is relieved. And so what this device is designed to do is basically maintain that space around the nerves that people get when they bend forward, try to maintain that when they're standing up. And so oftentimes, I'll talk with patients, and if they have substantial relief when they're sitting down, bending forward, and that reliably the pain and symptoms come back when they stand up, then oftentimes this will work very well. The research, the 5-year study that they did to get through the FDA to get this approved, showed that up to 80% of patients who had those symptoms no longer needed medications or any more injections or any surgery from the time it got put in up until they concluded the study at 5 years. And so this can be a long-term benefit for people with narrowing of the spine, and who reliably have those symptoms, improvement with flexion, worsening with extension. I mentioned earlier that this is not a substitute for surgery. And so oftentimes, this can be something that we can try, because the surgery, this procedure itself, takes me about 15 minutes to put in. And it's not done under general anesthesia. It's done under just twilight sedation. So the recovery on it is about, you're back to doing whatever you want at 4 weeks. And so the recovery on it's much quicker. So this can be a bridge to see if, well, maybe you don't need that bigger surgery, or maybe you're not a great surgical candidate. And so this can be something that can provide substantial and durable long-term relief in a minimally invasive approach. But if if it doesn't help, or if it doesn't work, or you're not a candidate for this, then I pass you along to Dr. Blizzard, and he's going to talk with you about direct decompression.
So a direct decompression is, I'm sure you've probably heard of the roto-rooter surgery. So this is the oldest spine surgery in the book. This literally means going in the back of someone's spine, removing the muscle off the spine, and cutting the middle of the spine bone away. So as surgeons, we name each individual vertebra a bunch of different things depending upon what part of the bone we're talking about. A lot of this is just to mystify surgery for all of you. But the part in the middle and the back, I call it the stegosaurus spike that sticks out. It's called the spinous process. In this picture here, the spinous process is a long pointy piece, and the part that attaches to it makes it look like a wishbone. That's called a lamina. So a decompression surgery is a laminectomy. We go in and we cut a trough out of your bone such that the nerves, which in this picture here are the yellow part, it now has no backstop. So previously, that triangle that we were talking about, I'm taking the whole top of the triangle off. So rather than it being pinched by the confines of that bony triangle, now there's no back on it, and the nerves have all the room in the world for them to drift back and occupy that space. So the basic tenets of how this is done has not changed dramatically in 50, 80 years. This surgery works very well for people that have that ligamentum that Dr. Kent was talking about, when there's too much ligamentum in there occupying that triangle. When there's people that have a disc in the front, we can cut the bone off the back, kind of slide the nerves out of the way, and then grab the disc out of the front. And also we have the ability to kind of reach our way around and hollow out space of the nerves that are leaving out to your body. So in this case, you can address central, which is right in the middle of the triangle, that kind of stenosis. Lateral recess, that's where the nerve comes out of the, we call it the sac of nerves. It was the spinal cord above, but down below it's called the sac. We can decompress that area where the nerves exit the sac, and we can also decompress the bony tunnel where the nerve lives on its way out to your body, called the foramen. So all three types of stenosis can often be addressed with this laminectomy procedure.
Okay. And the focus of this talk was primarily on lumbar spinal stenosis, but similar things can happen in the neck, and so we often deal with similar stenoses at various areas in the neck. It's a little bit different approach in the neck, and which is why we kind of decided not to address it today, and that could be definitely a talk for another time. The neck's just, there's not as much space. There are a lot more critical structures in the neck, and so it's a different animal, and so that's why we decided not to address that today. You have anything else you want to add before we open it up?
Just to muddy the water a bit about different surgeries that we do as surgeons for stenosis. In the instances where people's bones are moving abnormally, so they slide forwards and backwards, so you have a slip disc or a spondylolisthesis, sometimes that creates stenosis. I'd like to tell people to think about it as two different holes you're looking at, like a beading a necklace. If one slips by the other, suddenly rather than there being a continuous canal right down the middle, now it's kinked in half because one slid forward and it's kinking the hose. When that happens, oftentimes by just realigning the bones, that's enough to decompress the canal. So in some cases, we're able to do fusion surgeries for people that need them, that we don't need to actually go in and carve out the nerves like this and do that roto-rooter type surgery. We can get away just realigning them, and it can be a fairly minimally invasive way to treat that.
Okay. So from here, we'll take questions if there are any questions.
Yeah, we have our first question, and it asks, this would be addressed to either of you. What do you think about using the Dr. Hose belt for lumbar spondylolisthesis or stenosis?
I'm actually unaware what that is.
Is it? I'm assuming this is some sort of.
Sounds like a proprietary brace of some sort.
Some sort of brace for the lumbar spine.
Well, I'll jump in. I'll talk about the spondylolisthesis part. So when people's bones slide back and forth, there's nothing that we know of other than a surgery that will stop them from doing that. Now, with that said, it doesn't mean that when your bones slide, you're automatically condemned to having to have a surgery. There's many people who have bones that slide in an abnormal way that never bother them. In fact, there's some kids who have this develop in childhood that go 40, 50 years without having any symptom at all. But instead, they'll show up in their 60s and say, hey, my bones are slipping in this weird way and it bothers me now. It's not because necessarily it's a brand new problem, but it's a brand new symptom. So when people ask about whether certain therapies, certain braces, certain maneuvers can help fix a slip spine, nothing short of surgery will stabilize it, but it doesn't mean that other things can't help the symptom that results from the bones moving in an abnormal way.
Clarify that it's it is sort of like traction for the lumbar spine.
So again, that's a good example. So traction can temporarily make your nerves feel better. We talk about upside down traction, like the teeter hang-ups I'm sure you've seen on TV. That works great. Some people, when they bear weight, their disc collapse a little bit and their nerves get pinched. So the minute they lay down or hang upside down or sit in a pool or go to outer space, any of these things will take load off their nerves. So I generally tell people, if it works, great, you should do it. It's not going to harm you hanging upside down. If you can survive like a bat and live upside down all day, I tell someone they can go that way the rest of their life. In general, when I hear that people get a lot of symptom relief by hanging upside down, I tend to tell them, you're someone who would eventually do well with surgery if you needed it. And you're literally telling us that your body has a problem when you bear weight and the disc compresses.
I guess one thing to add about lumbar spinal stenosis and wearing any sort of, and this sounds like a specialized traction belt, but just prosthetics or lumbar support belts in general. If you think about what causes your symptoms, typically for when we're thinking about spinal stenosis, keeping that curvature in your spine, staying erect tends to cause those nerves to become irritated. And so wearing a brace that could potentially keep you in that extended position may make you feel worse. And so, that might not be the best option for patients with lumbar spinal stenosis. That being said, if that's something you want to try, that's something to try for symptom relief. But it's also not a great long-term option. And it kind of comes back to what we were talking about with physical therapy earlier, is when you are wearing a brace, daily, all day for long periods of time, your body, you're getting that extra support of your spine, and so your muscles don't have to be engaged to keep you standing and upright. And so what happens with that is your muscles start atrophying, and then it can be very difficult to start building up strength of those muscles. And so when people tell me they're wearing back braces, I tell them to wear it with caution, and I advise them not to wear it for long periods of time. It's fine, if you have an important event, you need something that it's gonna make you feel more comfortable for a few hours, here and there, then that's fine. But it's not something that I generally recommend people wear for long periods of time.
In general, if somebody feels more comfortable with the brace on, that is exactly the person I think would do better at physical therapy, because wearing a tight lumbar corset is like simulating a six-pack. So if you say, gosh, it feels amazing when I wear this tight corset, I would say you'd feel even better with a six-pack. Now, I can't throw stones like I have a six-pack and I have, but in general, that's what you're simulating.
We need to start doing six-pack surgery.
That's true.
All right. Are you ready for our next question?
Yeah.
All right. It asks, how are osteophytes a major cause of stenosis if bone density begins to decrease at the age of 30?
Great question. I'll jump on this initially.
Yeah.
So osteophytes or bone spurs happen anywhere on the body from an irritated joint. So arthritis just means inflammation of a arthrosis, so of a joint. Arthritis in Latin just means joint. So anytime your body gets irritated at a joint, it tries to produce bone. And there's different ideas of why that might be. Some people think it's your body trying to fuse the joint, so it's trying to make bone such that the joint will no longer be a joint. But it is completely independent of the quality of your bone. So you could have absolutely end-stage terrible osteoporosis with styrofoam type bone, and with arthritis, your body will still try to make more of that terrible bone as bone spurs. So somebody with really bad osteoporosis still going to have bone spurs, but they're going to be very weak bone spurs. Doesn't change what your body's trying to do. It will change how well it does it though. And the way that they cause stenosis, again, we talk about that triangle space that's reserved for the nerves. You have in the back of that triangle, you have your facet joints. So every level of your body is a stacked tripod where you have a big disc in the front and two matching facet joints in the back. So when I say the L4-5 level, there's an L4-5 disc in the front and two L4-5 facets in the back.
And these are the facet joints right here.
When those facets get overgrown and they develop bone spurs, the bone spurs can grow into the canal and start taking up part of that triangle space reserved for your nerves. So that's how the bone spurs themselves create stenosis. In this picture you see here, this is the facet joint. It looks kind of like a hamburger on its side. There you go, there's your patty and your bun on both sides. That patty area can grow And in this person, they grew extra tissue here, which was grown off of that hamburger and occupied some of that triangle. So this person still has kind of more of an hourglass figure now, but when this person was 15 years old, it was much more of a true triangle. And now, as this burger meat or whatever you want to say, lettuce,
It's lunchtime.
has grown out of the burger, it's now occupying part of that triangle. So the bone spur is this area right here, occupying the corner of the triangle.
Great question. I have nothing to add.
All right, and our next question asks, if you do the laminectomy, what protects the exposed spinal nerves once the spinous process is gone?
Excellent question. Your body, it's a very good question. The short answer is your body makes scar over the top of it. Anytime we take any tissue away anywhere in the body, your body will fill it with tissue. What kind of tissue? Just scar tissue. In a theoretical sense, if I tell everybody this, it's kind of unnerving to think about, but if you were to be shot in the back by an arrow, this area, once we take the bone away, you're more susceptible to get very hurt if they shoot an arrow into your back at that level. But anyone with a reasonable amount of muscle, tissue, skin are not going to be able to feel this spot. So it's not like you can sink your finger into their back and somehow push their nerves. There's geometrically and anatomically, there's more space than you think there. But in the long run, it really is true. The back of your canal is no longer protected. So in a theoretical chance, if you're going to go back in the old days where we had wars with arrows, you'd be more susceptible to an arrow injury in the back.
Okay, next question.
All right, our next question asks, are any of these treatments applicable to scoliosis?
Yes. So, I'll start up where, what I primarily focus on, medications, absolutely. This scoliosis is going to be involved with that. Physical therapy is important for people with scoliosis, especially, as the architecture of their spine changes with time. Oftentimes the body will compensate to a degree, but that degree of stenosis may get to the point where the muscles aren't able to overcome a lot of the the strengthening needed to keep the person upright and out of pain. And so physical therapy is excellent for people with scoliosis. Physical therapy long term is not going to change the curvature to a substantial degree to reverse scoliosis, but it can help build those muscles like we talked about earlier to basically help support the spine and help with pain. As far as epidural steroid injections, it makes them a little more difficult, but absolutely can be helpful for people with scoliosis. And then vertiflex indirect lumbar decompression, again, can be done with scoliosis. For this particular procedure, it kind of depends on the type of scoliosis and the degree of it, and whether there are other things such as spondylolisthesis, meaning shifting of those bones at that area, or if there's too much rotational scoliosis, then that can impact the ability to adequately deploy the device. But all these things would be on the table for someone with scoliosis.
When it comes down to scoliosis, it comes in a gigantic spectrum. There's some people who have very minor, just purely radiographic scoliosis that they don't know they have it till I tell them they have it. There's the other end of the spectrum where someone has such bad scoliosis they have to walk completely tilted over and have a hard time breathing because their lungs are so crushed by their alignment. And there's everything in between there. So when people have scoliosis, rarely are we operating on them just because of the fact they have scoliosis. Nobody ever comes in and says, I have no symptoms, please fix my x-ray. That just never happens. They come in with a symptom. So with scoliosis, you can get stenosis, you can get spondylolisthesis. These things all exist in a continuum and they happen together. So when it comes to stenosis, someone with scoliosis may have this very large curve, but only 1 or 2 levels where they're pinching their nerves. So these kind of local therapies we can try, like a steroid injection, might work really well for someone with a scoliosis if their problem is specifically pinching of the nerves just at 1 level. So scoliosis is kind of a big overarching term that not all of them are treated the same way. There's a huge spectrum for what we do between just observing it and telling you about it versus large reconstructive surgery. Again, absolutely everything in between those two.
All right, our next question asks, what percentage of people who've had laminectomies have to have a fusion in the future?
That's a very good question. It has everything to do with people's age, the severity of their stenosis and their alignment, and any ongoing instability. So it's difficult to just answer the question with a straight percentage. In general, At least 10% of people that have a laminectomy will go on to a fusion within 10 years. That number has been published to be as high as 30% and as low as 0%, depending upon what study you're talking about and how many people were in those studies. Again, just like scoliosis, there's a large spectrum of people that undergo a laminectomy, and for many different reasons. Some people, at the outset, I could say a fusion is an option, but a laminectomy may make you better for several years and put off a fusion for several years. Other times I say a laminectomy might put this off for decades. It has to do with what their spine looks like, and it's kind of comparing apples to oranges without looking at individual cases.
All right, our next question asks, I have an appointment to get physical therapy at Access Spine Center for pain in the L4 area. Will the current x-rays be analyzed for any additional treatment recommendations? And also they mentioned that they've been going through a course of spinal decompression, and they ask if that's very successful. I'm not sure what I'm gonna ask for clarification.
So I would say our physical therapists here at our office are very dedicated to looking at our imaging and asking any questions to any of the physicians here about what we think is safe and not safe. And whenever I send someone personally to physical therapy, I tell them the goals of what I want them to accomplish and essentially the radiographic problem that I see as the cause of that. So with that said, they do absolutely look at your x-rays. They have access to the x-rays the same way that we do. And I frequently answer questions for them about what my opinion would be on something, regardless of whether I've seen the patient or not.
I think that's one of the advantages coming to Access Spine is that we do have our physical therapists, we have our chiropractor, we have all these people are right next door. And so if there are any questions or, I had a patient the other day who wasn't doing well in physical therapy after an injection, and I just popped over there, said hello, and, asked him a few questions, and I actually got him in with Dr. Blizzard the next week. And so that is not uncommon here at Access Spine. I think that's one of the advantages of us, because we have all these multiple disciplines working closely together.
To answer the question about spinal decompression, a lot of chiropractors and physical therapists will use this essentially in a barbaric way. It's almost like drawing and quartering someone. In general, I would tell people I don't think this is going to fundamentally change the severity of what you have, but if it symptomatically makes you feel better, I'm absolutely going to encourage you to do it. And again, not to be sarcastic, but there's virtually nothing that I can think of aside from high dose narcotics that I would discourage you from if it makes your back feel better. If you say, you know what, if I lay on the ground and stretch a certain way or do yoga, my symptoms feel better, I'm going to tell you keep on doing that every day and do it as long as you can. And someday when that stops working for you, then we talk about higher echelons of treatment. But if you say spinal decompression makes my back feel better for 3 days and I go twice a week and it gets me through and I'm putting off surgery or more intensive treatment, by all means, you should continue that.
And we don't treat imaging, we treat people. And so when people come to see us, the imaging is part of the evaluation, but it is only a part of it. It doesn't matter what we see. If patients come in and what we would expect by seeing their imaging, the patients don't have these symptoms that support that, then there's absolutely nothing that we need to do about it.
In general, the treatment that works best for people is the treatment that people think is working for them. And it's not to say that people can be tricked into things working, but there's many treatments that work for one person that some other person would say, I tried that, it's total hogwash, it doesn't work at all. For somebody else, it might work very well. And for that person it works well for, they should keep on doing it.
All right. Our next question is, it's actually two related questions. If you need a laminectomy at L5S1, what would be the likelihood of needing one at L4-5 a couple years in the future? And then the second question is, how many laminectomies can be done in the spine?
Well, I'll answer that one first. Every level of your spine could have a laminectomy, every level, from C1 down to S1. The chance of needing another laminectomy after having one is everything to do with each individual person and what's on your imaging. In general, the way to stem off further degeneration of your spine is just to never move again. So some people say, I had this treatment and then I had to have another one. I tell everybody that's like saying you were hungry, you ate a meal, and then you got hungry again. And the reason you got hungry again is because you ate a meal. The answer is, well, I guess kind of. So the longer you live, the more every joint in your body will degenerate. That's just a secret I'll share with everybody. So in general, if you have a treatment, it works well, it doesn't mean that every level in your body is not going to continue to age and degenerate. So if you have a 5-1 laminectomy and you keep on living and the level above degenerates, the longer it gets used, it may need to be addressed. But the chance of it needing to be addressed and how soon it would be addressed, it just varies person to person. It varies with things like smoking, body weight, activity, age, medications, everything factors into it. So it's kind of a person to person basis, and it's comparing apples to oranges, comparing you to your friend or somebody else.
Thank you. All right, our next question asks, for someone who has been taking opioid pain medications for years, does this limit the surgical options that they have available to them?
In general, people that take high dose opioids develop a tolerance. I think everybody knows that. And sometimes, we use these things as surgeons sparingly. I use them after surgery to treat surgical pain that I know I'm going to create and I know that they're likely to get better from. When you take them in a chronic sense, the danger you run into is you need more and more of them to create an effect. And someday, if you need a surgery, the effectiveness of the surgery, and especially your ability to tolerate the recovery afterwards, is going to be infinitely harder. So I tell someone, if you're on narcotics for years and years before surgery, you are not going to enjoy the period immediately after surgery, because it's not like we have a secret medication we're not telling you about that we give to those people that's not available to everybody else. No, all we have is the same medications. If you're already tolerant to them, you're essentially going to go through surgery with much less pain relief than the average person. The other thing is, we have good studies showing that people that are on narcotics before spine surgery, regardless of how well the surgery is done, how good radiographic it looks, how much better your function is, people that are on narcotics before surgery have a very, very high likelihood of need to be on them afterwards. So that's the reason we tell everybody, do everything you can to wean down and get off of narcotics before surgery, because that will maximize your chance of long-term getting off them with a successful surgery.
And when you're on opioids for a long period of time, your brain and your nervous system undergoes changes to basically accommodate for years of having those opioid receptors blocked. People who are not on opioids, everyone has these receptors that your body makes these natural hormones that basically occupy those receptors normally in a periodic pattern based on things you're doing to provide pain relief, provide joy, provide a lot of different things. And so when you block them for a long period of time, your brain and your nervous system accommodates for these and actually is shown to be more sensitive to stimuli, in the future. And that's part of the reason why we see these studies where, people who are on these opioids for long periods of time tend to have more pain and more issues after surgeries, because your body with time accommodates and changes, and it's really hard to reverse those changes.
Excellent. All right, our next question asks, if I've had 2 previous laminotomies, can injections help?
Absolutely, and it depends on what's causing the continued pain. And so, sometimes when people have these surgical procedures, they'll follow up with their surgeon afterwards. They're still having pain. They're still having the symptoms, that they had before the surgery. They'll oftentimes repeat imaging will be done, and if everything looks good, oftentimes, especially in the short term, when your nerves are kind of getting used to having a little more space around them, they can be irritated. And so we'll use epidural steroid injections to help calm those nerves down while your body's healing. And so that's one way we use them. For people, who've had surgery a long time in the past and they're continuing to have symptoms, if there are new issues developing that are causing pinching of these nerves, then they should respond to these epidural steroid injections. And also, anytime you have a surgical procedure done, Dr. Blizzard was talking about, the scar tissue that forms. Well, when you're getting close to those nerves, sometimes people's bodies react differently and form more scar tissue, and sometimes that can start irritating nerves itself, and so that can be a very difficult thing to treat surgically, and that can be something we can help with these injections. When that happens, there's also, we can try these other newer therapies such as it's been around since the 80s, spinal cord stimulator therapy, which can, when we look at an imaging, the nerves look decompressed, they're still having pain in the back, down the legs. Oftentimes that's where these spinal cord stimulators come in, because they are very effective in treating that type of pain.
So we talked about after any surgery we have, where we take a pinch off a nerve, that nerve will finally, if it's been confined to a very tight space and you finally give it the room it wants, that nerve will have the first time in a long time to actually swell. Whenever you pinch a nerve, it wants to swell. Just like a swollen ankle, it wants to swell up. So frequently after surgeries, I'll free a nerve up and someone will wake up and say, wow, it's totally gone. It feels amazing. And they'll call me days later saying, oh my gosh, it came back. I must have had a new herniation or something must be wrong. In reality, what that is that nerve that's been pinched for so long is finally have the chance to swell, and it's swelling, it swells, and finally it swells so big that it really does get tight again. And those patients are the ideal candidates to have an injection to calm down that new inflammation. Because in reality, the space we leave them with will be enough for that nerve once it calms down, but it's swollen up as big as it could possibly be because it hasn't been able to do that in years because it's been pinched. In the other category, he's right with scar tissue. Anytime we do a surgery, anytime that surgeon touches any part of your body, you make a scar. There's no way around that. Your body does a scar to try to help you and heal you. At the same time, if it makes too much of it, it can hurt you. If there's a certain spot where a nerve's living and it needs every bit of space and your body forms scar tissue around it because we're around that nerve and we touch the nerve, it can form scar tissue in a way that's not safe to go remove. And those patients, they can do very well with spinal cord stimulators, sometimes periodic injections. There's different options for them. In my mind, the ideal candidate for a spinal cord stimulator are patients that we've operated on, that we address, we clear up all the compression on the nerves, and they still have some symptom that makes us think the nerve is compressed. We look at the imaging, we say, we don't see any ongoing compression. The nerve can just be permanently irritated from it. And a spinal cord stimulator can really be life-changing for those people.
All right. I think we have time for one more question. What do you think?
All right.
Sure.
It asks, if I'm 50 and relatively healthy, wouldn't it be better to have surgery when I'm young and heal faster rather than put it off for 5 or 10 years?
I tell everybody, there is no bonus points for going early and doing prophylactic surgery in the spine. With that said, the things that I think should govern your decision for whether to proceed on with surgery or not is, number one, trying everything that's not surgery first. So if I have a disc herniation, I'm a surgeon, I get an MRI, I say that's a big disc herniation. You know, I think there's a good chance I'll need it to be removed. First thing I'm going to do is do physical therapy. I'm going to take anti-inflammatories and I'm going to try to ignore it. Even though I know what it is, I'm going to try to ignore it. The next step is I would try an injection to try to calm down the irritation on my nerve from the herniation. Why? Because I know that works. And second of all, I know my body's going to try to repair it. My body's going to try to eat away the disc herniation if I give it time. I'm going to try to buy my body time. However, if the only way that I can survive is by taking narcotics and by not moving at all, I don't think those are reasonable things for a 50-year-old to not be doing. If you say, gosh, I don't have to have surgery, but all I need is these high-dose narcotics and I just lay in bed all day long, that's not a solution. If all you need is Tylenol and occasional ibuprofen and you can go about your day, and at the end of the day you have a little bit of soreness, I don't think that's someone who needs surgery either. It's somewhere in between. You do everything you can but surgery until your activity gets driven down to what you're not willing to tolerate. So you have to define that for yourself. Say, you know, what are the things I enjoy in life? And you say, I live to fish, I live to hike. The minute you start giving that up and there's a fixable solution for you, you go after the solution at that point in time. But if you can fish by taking some Tylenol, doing physical therapy, taking some ibuprofen, you can get out and do what you want to do. I think you do that until you wear out that treatment.
That's a great point. That's what I tell all my patients. You know, my goal is to get you back doing what you want to do, and that's, you know, all our goals. And so everyone's going to have a different threshold for that.
All right, thanks for attending, everybody. We'll be recording this and uploading it to our YouTube channel, just like our last talk. So
if anyone has any requests for any future topics, you guys can go on to the YouTube.
Currently, comments are
disabled.
Yeah.
Well, you can contact our office if there's a topic you'd like to have us discuss, and we can put those ideas together and try to come up with a topic that people are interested in.
Yeah, certainly.
All right. Thank you, everyone, for joining.